students, welcome to this session. In this session, we will be talking about a very important topic, that is alcoholic liver disease. Now, alcoholic liver disease means in detail we will be discussing about the metabolism of alcohol, how it happens in the liver, and what is the consequence of consuming too much of alcohol for a long duration. Okay, and that predisposes to one of the chronic complications of alcoholic liver disease, that is cirrhosis or end stage liver disease. So with that note, we will see what we are going to learn in this session. First, we will see what is alcoholic liver disease and the predisposing factors for alcoholic liver disease. Like, so many people consume alcohol, but only few will have complications. Why not the others? Then we will talk about the mechanism of injury, how the injury happens in the hepatocytes, as well as the pathogenesis or the exact ways in which the different tissue in the liver is affected. Then we will talk about the stages of alcoholic liver disease, that is steatosis, okay, and then steatohepatitis, and the third is cirrhosis or the end stage of liver disease. Okay, so first steatosis, steatohepatitis, as well as you will talk about cirrhosis and their specific pathological finding or what we find in the biopsy. Then we will see a detail about cirrhosis, because cirrhosis is an important topic where you may get a case scenario or you may get a short note, you may get MCQ type questions in relation to cirrhosis. Then we will talk about the classification of cirrhosis according to etiology, according to morphology, and the complications that come because of cirrhosis. In the end, we will discuss little bit about non-alcoholic fatty liver disease, which simulates alcoholic liver disease, but the history of alcohol consumption is lacking in non-alcoholic liver disease. Then we will talk about one hereditary condition, that is hemochromatosis, which is another common cause of predisposing the liver to cirrhosis. So as usual, we will start our session with a case scenario. So here comes a 62-year-old male with history of chronic alcohol abuse for a long duration, that is 20 years. And now he complained of gradual weakness, anorexia, and weight loss. On evaluation, he had jaundice, he had spider angioma, as well as gynecomastia. Abdominal evaluation revealed patient had ascites as well as splenomegaly. Now I hope you have got an answer to what clinical condition the patient is going through, but if you have not got it, then we will discuss it. Okay, so he has weight loss, he has weakness, and he has anorexia. Now all these three are non-specific symptoms. Okay, non-specific symptoms, they can come in any disease. Then he has jaundice, spider angioma, and gynecomastia. All these three indicate that he has, you can say, increase in estrogen levels. Okay, so increase in estrogen levels along with jaundice, if you have, then it is more likely indicative of a liver pathology. And now if you add ascites as well as splenomegaly, then that explains everything, that most likely he is having a condition or an end stage kind of liver disease, that is cirrhosis. Okay, now why cirrhosis? Because cirrhosis can lead to you can say decrease in protein levels or serum proteins, and that can explain the ascites. And because of cirrhosis, there can be portal hypertension, and portal hypertension can lead to splenomegaly. So that is how all the clinical scenario can be explained. Now what is the most probable diagnosis? The most probable diagnosis is cirrhosis of liver. And what could be the etiology? Because he has been consuming alcohol for almost 22 years, so most likely the cause of cirrhosis is related to alcohol or alcoholic liver disease. The second question, describe the etiopathogenesis of the disease, we will be discussing throughout the session, and then list the different forms of disease associated with alcohol. Here you will have to write the three stages: steatosis, then you have steatohepatitis, okay, here no inflammation, here inflammation, and then the cirrhosis. So all these three stages you will have to describe in detail. Okay, so now we go to the fourth question, that is describe the morphological changes in the target organ, and I have already told you, so you have to elaborate on these three conditions. Then now we will go to alcoholic liver disease. So alcoholic liver disease occurs because of chronic excessive consumption of alcohol, and this is the major cause of alcoholic liver disease, or most important cause of cirrhosis of liver. Three distinct lesions with overlapping features are encountered in the liver in alcoholic liver disease, and they are hepatic steatosis, which means fatty liver or accumulation of fat. Okay, accumulation of fat in the hepatocytes is called as hepatic steatosis. The second is alcoholic hepatitis. Now steatosis may progress to hepatitis, and that will be called as steatohepatitis, or without steatosis, if there is hepatitis, then it will be called as only hepatitis. Okay, and here there will be inflammation, whereas in steatosis we do not have inflammation. Then the end stage, or that is alcoholic cirrhosis. So these are the three distinct lesions in liver that we encounter with chronic alcohol consumption. So what are the risk factors or predisposing factors for alcoholic liver disease? Because I have already told again that many people consume alcohol, but only few are predisposed. So it depends on the amount consumed, and that is the most important factor. So what is the amount? Minimum 80 grams per day. Say if you consume for 8 to 10 years, then you are likely to develop alcoholic liver disease, and that may progress to cirrhosis also. Okay, so that is the amount of alcohol, then the duration of consumption. As we saw in our case scenario, the patient was consuming alcohol for almost 22 years. So duration also has an effect on the outcome. Third is gender. Now when you compare male to female, female are more susceptible to alcohol liver disease. That is because estrogen increases gut permeability to the endotoxins, okay, and these endotoxins come from the gut bacteria, and these increase inflammatory cytokines in the liver, okay, and these inflammatory cytokines will injure the hepatocytes and they will cause fibrosis. Okay, so that is how women in general are more susceptible as compared to men. Then there can be ethnic as well as genetic differences. Now ethnic and genetic differences mean that we have all have different enzymes which have different potential for metabolizing alcohol. Okay, the two enzymes are alcohol dehydrogenase as well as aldehyde dehydrogenase. Okay, so these are the two enzymes that are responsible for metabolism of alcohol. But in persons, or you can say the enzymatic activity or the potential enzymatic activity is different in different persons. So you and me will not have the same enzymatic activity of alcohol dehydrogenase as well as aldehyde dehydrogenase. So the consumption in alcohol in you and me can have a different manifestations. That is about the polymorphism of enzymes involved in alcohol detoxification. Then comes the fifth, that is comorbid conditions. Now suppose a person is consuming alcohol. Let's take example, one normal person takes alcohol, another person is hepatitis positive, okay, is hepatitis positive, B positive, consumes alcohol. who do you think will have a more worse outcome, whether the normal or the hepatitis B positive person? So the answer is the hepatitis B positive person will have a worse outcome or is more likely to develop alcoholic liver disease as compared to a normal person. And that is the comorbid conditions, like you have iron overload, that is called as hemochromatosis. It can be metabolic syndrome and associated with non-alcoholic steatohepatitis, or the patient may be having a comorbidity with hepatitis B and C infection of liver. Okay. After the predisposing factors, let's have a look at the ethanol metabolism, or how alcohol is metabolized in the hepatocytes. Okay. And all these steps happen in the cytoplasm of the hepatocytes, where you have the alcohol as well as aldehyde dehydrogenase. Okay. So this ethanol is processed with the help of alcohol dehydrogenase, and that is converted to acetaldehyde. And in this step, NADH is liberated. Now aldehyde goes into mitochondria, and that is converted to acetic acid. Again, NADH is generated. Okay. In addition to that, while this metabolism happens, there is also microsomal activation, and this microsomal through CYP2E1, which is a family which belongs to the family of cytochrome P450 enzyme, and that in the microsome will cause reactive oxygen species or release of reactive oxygen species, and this reactive oxygen species will cause free radical injury. Okay. And then there can be also through catalase enzyme in the peroxisome, alcohol can also be converted to aldehyde. Okay. So in this step we have seen that aldehyde is formed as well as NADH is generated. In addition to that, you have reactive oxygen species coming from the microsomes. So what is the mechanism of liver injury? The first point you have to remember in detail all the mechanism, and the first point is oxidative stress or a reactive oxygen species injury. Okay, or free radical injury. Now how does this happen? I have already told you alcohol metabolism by CYP2E1 produces reactive oxygen species, and these reactive oxygen species causes lipid peroxidation. Okay, lipid peroxidation, and this lipid peroxidation leads to cell injury or hepatocytic injury. Then in addition to that, aldehyde metabolism in mitochondria also generates reactive oxygen species. The second is increase redox potential. Now if you see in each step NADH was generated, so here the NADH ratio will be in favor of NADH, or NADH will be markedly increased, which will affect or which will inhibit fatty acid oxidation, and this will lead to accumulation of fat. Okay, and this accumulation of fat is called as steatosis. Okay, and once there is fat, then fat can undergo lipid peroxidation, and that can lead to cell injury. Then in addition to that, also the methionine metabolism is affected, and methionine is an important component of glutathione reductase, which helps us or which helps to protect us from free radical injury or reactive oxygen species. So once methionine metabolism is affected, our glutathione peroxidase will also not be effective or will be deficient. So again, there is more chance of reactive oxygen species, or you can say free radical injury. Now that was the two important ones, the oxidative stress as well as increased redox. Now we come to the third, that is immune and inflammatory mechanism by chemical adducts. Okay, so the adducts, how they are formed, the acetaldehyde combines with the proteins to form adducts, and as we know that enzymes are also protein, so these acetaldehyde will connect with the enzymes, and then it will interfere with normal enzymatic activity. In addition to that, acetaldehyde also forms chemical adducts with proteins, and that will form neoantigens, and against these neoantigens there can be inflammatory response. Okay, so this is how the third mechanism, that is immune and inflammatory mechanism by chemical adducts. Now the fourth is increase pro-inflammatory cytokines, and this happens because of lipopolysaccharides or endotoxins that come from the intestine and they go into the portal circulation. So what happens with the consumption of alcohol? The LPS plus endotoxins, they come into enteric circulation, okay, and they, once they are into enteric circulation, they will go into the liver and they will stimulate inflammatory cytokines, and that will cause hepatocytic injury. Okay, so the fourth mechanism is increase pro-inflammatory cytokines, and these endotoxins, they come from the enterohepatic circulation. Next is malnutrition and deficiency of enzymes. So these are some of the common causes which predispose, or you can say the mechanism which predispose to alcoholic liver disease. Now we will see what is the pathogenesis, or we will just revise whatever we have learned in a pictorial representation. We will see how all that happens, whatever we have learned till now. Okay, so here is alcohol consumption on the top, and in the middle you have destruction of hepatocytes. Now this destruction of hepatocytes is an important step, and here is consumption of alcohol, and then there needs to be a genetic susceptibility also. So without a genetic susceptibility, a disease cannot happen only because of environmental factor. So if genetic susceptibility is present and then you have an environmental factor like alcohol, then a alcoholic liver disease can happen. Okay, so once alcohol is consumed, it will be converted to acetaldehyde. Okay, this acetaldehyde can directly cause injury, or they can directly activate the stellate cells, or this acetaldehyde is processed in the mitochondria. In the mitochondria, we saw that NADH was generated, so that will increase the redox potential, as well as it can cause oxidative stress through lipid peroxidation as well as low glutathione synthesis. The other way is acetaldehyde can form adducts with chemical adducts as well as protein adducts. So protein adducts is with the enzymes. With the chemical adducts, what it happens, it causes neoantigens. Okay, with these neoantigens will stimulate the immune system, and there will be inflammation just like a autoimmune disease like, and this will again cause destruction of hepatocytes. The other we learned through gut permeability, and when you consume alcohol, the gut permeability increases, so the endotoxins from the gut can enter into the circulation, and from the portal circulation they will go into the liver, and there's increased production of pro-inflammatory cytokines. Now these pro-inflammatory cytokines will activate the stellate cells present in the space of Disse, and the stellate cells will cause collagen deposition, and this collagen deposition will lead to fibrosis. So if we revise all these, then first acetaldehyde is formed as well as some reactive oxygen species. So once there is reactive oxygen species, they will cause oxidative damage to hepatocyte membranes, and then they will also form protein acetaldehyde adducts. Now these adducts interfere with normal enzyme activity, and that can lead to cirrhosis. The other pathway is Kupffer cell activation, and this Kupffer cell activation will lead to profibrogenic cytokines, and these cytokines will activate the stellate cells, and these stellate cells increase collagen synthesis as well as extracellular material in the space of Disse, and this will again lead to cirrhosis. Okay, so this is the revision. So you can very pretty well now write the mechanism as well as the predisposing factor for alcoholic liver disease. Now as we move on, we will discuss the detail how hepatic steatosis looks like, what is the morphology, what is the clinical presentation, and this hepatosteatosis is the earliest or an early change of alcoholic liver disease. Now there is no specific clinical symptoms, and it is a reversible stage. Okay, so if the person stops taking alcohol, then steatosis will go back to normal liver. When we do a liver function test, there will be mild elevation in bilirubin as well as liver enzymes. Now what are the liver enzymes? That is AST and ALT. And one typical feature that you find in alcoholic liver disease is that AST by ALT is always greater than 2. Okay, so that is a very important feature that helps you to identify that the pathogenesis is most likely, or the liver injury is more likely, because of your alcohol. Next comes gross. When we see an autopsy specimen of a person who is suffering from hepatic steatosis, the liver will be enlarged, it will be soft and greasy. Also, it can be yellowish appearance depending on the amount of fat. Okay, and you cannot imagine that the liver from 1.2 can go up to 4 to 5 kg. So normal is 1.2 to 1.5, and because of this steatosis, the liver mass or the liver will be so much enlarged and the weight can be going up to 4 to 5 kg. And when we take a section, what shall we find? We will find the earliest change is in the zone 3. The zone 3 is around the central vein. Okay, if you recall our first session on normal liver pathology as well as the fundamentals, then you can know that zone 3 is close to the central vein, whereas zone 2 is intermediate and zone 1 is close to the portal tract. Okay, portal tract. So it is more perfused, whereas zone 3 is less perfused, but here the alcohol dehydrogenase enzyme is more in the zone 3 and it is less in the zone 1. Okay, so the earliest change will come in zone 3, and that is because alcohol dehydrogenase is located there. Then there will be microvesicular steatosis. Now microvesicular means small vesicles, okay, small droplets, and that can progress to macrovesicular steatosis if the person continues to take alcohol. So the small will coalesce and they will form a big vesicle that is called as macrovesicle, and the nucleus in the adipocyte will be pushed to the one side. Okay, so the nuclei will be pushed to one side because of the large big vesicle of fat. And this microvesicular steatosis is very common in alcoholic liver disease, and there will be no evidence of any inflammation. So if you see this, these small white are actually droplets of fat, and that is microvesicular. Okay, and then here in the actual picture also you can see that there is microvesicular change in this area, whereas in this area you are finding macrovesicular change. If you see this picture, then here the nucleus in all the hepatocytes is pushed to one side because the fat globules, they coalesce and form big vesicles, and that is called as macrovesicular steatosis. And if you see the real picture, then here you can make out that it looks like a adipose tissue. Okay, the liver biopsy or the liver tissue simulates like a adipose tissue because there is a lot of fatty change. Now what is the pathogenesis of fatty liver? It is just the similar what we have discussed in alcoholic liver disease, but just in order to fix it in your memory, we will revise again. So alcohol metabolism generates NADH, and that reduced fatty acid oxidation is also there. Now increased fatty acid synthesizing enzymes are also there. There is reduced fatty acid oxidation as well as increased fatty acid synthesis, and this will lead to fatty liver. In addition to that, there can be impaired lipoprotein assembly in the liver and as well as increased peripheral catabolism of fat. So all these will come to the liver and they will cause fatty liver. Okay, so that is the pathogenesis of fatty liver. Now we move on to the next morphological manifestation of alcoholic liver disease, that is alcoholic steatohepatitis. Okay, here you will have fat deposition as well as hepatitis, means there will be inflammation. So what can happen? Steatosis can lead to hepatitis, or hepatitis as such can be the first manifestation of alcoholic liver disease. Again, the symptoms are non-specific: anorexia, weight loss, as well as abdominal discomfort. When the liver function test is done, patient will have marked elevation of AST and ALT, and the ratio will again be more than 2, and this is indicative of the etiology, that is alcohol induced. Now bilirubin, alkaline phosphatase and GGT will also be raised, but they will be minimally raised. Okay, ALT and AST will be more than 10 times. Okay, whereas your alk phos and GGT will be minimally increased or elevated, because GGT and alk phos, they come from the biliary epithelium, whereas ALT and AST, they come from the hepatocytes. Okay, so because there is hepatocytic injury, so there will be ratio, or AST by ALT ratio will be more than 2. In addition to that, now because the patient has progressed little bit, so the albumin may also be reduced because of decreased synthesizing activity of liver. So albumin may be reduced. In the blood, you will find neutrophilic leukocytosis. So there will be leukocytosis. So WBC count will be more than 11,000. Normal is 5 to 11. And then you will have leukocytosis, and then there is neutrophilic, means in the DC or differential count, your neutrophils will be predominant, or say maybe around more than 90%. Okay, so that is neutrophilic leukocytosis. In the urine, you will find bilirubin as well as urobilinogen. And then when the liver is examined grossly, the liver will be enlarged just like fatty liver disease, as well as it will be yellow in color, but the consistency here will be little bit firm as compared to the soft consistency that is seen in fatty liver or steatosis. So when a section from alcoholic steatohepatitis is examined under the microscope, what will you expect? You will expect to see all the changes in zone 3, or that is perivenular, around the central vein. Okay, and then you will also see ballooned hepatocytes, and these hepatocytes are enlarged because of fat, water as well as proteins. You will find spotty necrosis or individual hepatocyte necrosis, as well as apoptosis of hepatocytes. Then you will find neutrophils coming to the site of inflammation around the balloon and necrotic hepatocytes. So necrotic hepatocytes as well as ballooned hepatocytes, so around them you will have neutrophils coming as satelitosis. So neutrophils will come and surround them as satellite, so this is called as neutrophilic satelitosis. Then you will have Mallory-Hyland bodies, otherwise called as Mallory-Denk bodies. Okay, so these Mallory-Hyland bodies are characteristic of alcoholic liver disease, but not specific, because Mallory-Hyland can be seen in many other liver diseases. So if you see this picture here, there is apoptosis, or you can say necrotic hepatocyte, and then it is surrounded by lot of neutrophils. So neutrophilic leukocytosis, and these white ones, whatever you are able to see, these pale ones are all ballooned hepatocytes. In the inset, it is shown the eosinophilic substance in the cytoplasm is the Mallory body or Mallory-Denk bodies, and these are nothing but accumulation of intermediate filaments, and that is most commonly CK8 and CK18, and this can be a MCQ. Okay, so Mallory-Denk bodies are accumulation of intermediate filaments. Then you can find this, already I have described, these Mallory-Denk bodies are eosinophilic cytoplasmic inclusions, and they are intermediate filaments, that is cytokeratin 8 and 18, and this can be MCQ. And if you see this picture, the animated one, here you can see the Mallory bodies within the hepatocytes, as well as you can see some steatosis, you can find perivenular fibrosis, you can find ballooning degeneration, you can also find neutrophilic infiltration. So once you have steatosis plus inflammation, that is called as steatohepatitis. Okay, so this is about the microscopy. You can also find some amount of portal and lobular lymphocytic infiltrate. The fibrosis will start in the perisinusoidal region from here, and that is typically called as chickenware type of fibrosis. Now this is again a MCQ, that chickenware type of fibrosis is seen in the perivenular region of alcoholic steatohepatitis. Now we have learned about steatosis, we have learned about steatohepatitis. Now what is the relationship between steatosis, hepatitis and cirrhosis? If you see, this is normal liver. Normal liver, if somebody consumes alcohol, can go to steatosis, stops taking alcohol, it reverts back to normal. Now steatosis is there and the person continues to take alcohol, it can progress to cirrhosis, or steatosis can go to hepatitis, and then hepatitis or repeated attacks of steatohepatitis will lead to cirrhosis. Okay, so if you see here the arrows, then you can remember that hepatitis as well as steatosis are a reversible condition. Okay, reversible. Whereas once cirrhosis happens, it is a irreversible condition because there is lot of fibrosis and fibrosis doesn't go back. Okay, and then you have to remember that normal liver can go to steatosis, steatosis can go to hepatitis, but it can so happen that steatosis can directly go to cirrhosis, or normal liver can go directly to hepatitis without going through a steatosis phase. So if you see this animated diagram, then you can understand normal liver, and then here it is hepatitis, it is steatosis, and this is cirrhosis with diffuse nodular architecture as well as regenerating nodules. Okay, and like whatever I have explained here, normal liver can go to fatty liver can revert back, as well as normal liver can go to hepatitis, and hepatitis can again revert back to normal. But once cirrhosis is there, it is just one way and it does not come back to normal. Now comes the third entity, that is alcoholic cirrhosis, or the end stage of liver disease. Now this is a chronic irreversible, I have already told it is a irreversible end stage disease, and in this condition patient will have jaundice, weight loss as well as ascites. Ascites is usually not encountered in case of steatosis and steatohepatitis, but ascites, if once it is there, you have to consider a possibility of cirrhosis. When we do a liver function test, again like them, there will be hyperbilirubinemia, there will be elevated transaminases, but one thing important here is reversal of A:G ratio. Now what does A:G means? This is albumin and this is globulin. Okay, normally in serum albumin is more than or much more than globulin, but in cirrhosis what happens, because of the stimulation of reticuloendothelial system, so there is a reversal of A:G ratio, or you can say G increases is, or you can say G is more than A in case of cirrhosis. When we look at the blood findings, there will be anemia or pancytopenia. In steatohepatitis, it was neutrophilic leukocytosis, or you are having neutrophil and there will be leukocytosis, but here there is anemia to pancytopenia, and that could be because of many causes, and one of them is nutrition. The other important thing is hypersplenism. And how does hypersplenism happen? Because cirrhosis will lead to portal hypertension. Portal hypertension will lead to splenomegaly, or it is called as congestive splenomegaly. Now this congestive splenomegaly will induce hypersplenism. Hypersplenism will cause pancytopenia. Okay, and then you will also have the prothrombin time prolonged. because liver has by now stopped synthesizing all proteins. And if you do a biochemical investigation, then the increase in blood ammonia will also be there because of decreased clearance by the liver. So these are the findings, or you can say liver function, blood finding as well as biochemical finding. And then we go to examine the gross specimen, or how does liver look in gross. So they were both enlarged, or you can say steatosis as well as hepatitis, the liver was enlarged. Okay, and I told you it can go up to 4 to 6 kgs, but here you see size progressively becomes smaller. So as the disease goes towards cirrhosis, the size becomes smaller and smaller, and the shea color will be brown. Now it will be non-fatty, it will be nodular, and then it will be firm to hard. Okay, so this is the feeling, whereas there it was firm, and in steatosis it was very soft to feel. When we examine under the microscope, you will find loss of normal architecture in the form of lobule, acini, and because of the death of cells. Then there will be regenerating hepatocytes which will form nodules, and they will be surrounded by fibrosis, and this fibrosis is progressive, and this fibrosis can be from central vein to portal as well as portal tract to portal tract. So if you remember, here this is the central vein, here portal tract, here portal tract, here portal tract. So if this fibrosis happens and there is progressive fibrosis, so it can happen from central vein to portal tract or from portal tract to portal tract, and that will give rise to a nodular appearance. In cirrhosis, there will be lot of fibrosis, and let's see how this fibrosis happens. So the pathogenesis of fibrosis in cirrhosis. So if you recall our first session on liver pathology, I have told you the principal cell involved behind this fibrosis is the stellate cell, or it is called as Ito cells, and they are located in the space of Debasis. Okay, and once there is all the inflammatory cytokines as well as the toxins as well as reactive oxygen species, all of them activate the stellate cells, and the stellate cells will be converted, or this quiescent or silent stellate cells will be converted now to active myofibroblast, and this myofibroblast will cause extracellular matrix deposition or collagen deposition in the space of Debasis. So here you can see there is increased collagen in the space of Debasis, and then there will be loss of fenestration, which is otherwise called as capillarization. So, and this will lead to the fibrosis in liver, and how this fibrosis progresses, it is first in the perisinusoidal or pericellular fibrosis. This is called as chicken wire fibrosis, and this starts in the zone 3. Okay, and these will progress to portal as well as periportal fibrosis, and then there will be bridging fibrosis, that is central vein to portal, or it can be from one portal to another portal, and then that will lead to nodules of regenerating hepatocytes. This is RHH is regenerating hepatocytes, and then in between will be areas of fibrosis. So this is how a cirrhotic liver will look like in microscopy. So if you see the gross specimen of cirrhosis, this is how it will look like. The surface will be nodular. Okay, and the nodularity corresponds to regenerating hepatocytes. Okay, and the dimpling or the depth, that corresponds to the fibrosis. So these nodules are actually regenerating hepatocytes. And if you see it in microscopy, here you can see the nodules and intervening areas, the blue areas. This is a Mason's trichrome stain in which the collagen appears blue, and so here there is lot of fibrosis separating the hepatocytes into different nodules. So it is diffuse remodeling of liver parenchyma into nodules separated by fibrous stroma. That is the definition of cirrhosis, and it is a end stage liver disease. Okay, so grossly shrunken, or that will be reduced in size, fibrotic, firm liver with uneven nodular surface. Remember one thing, cirrhosis is not a diagnosis, it is just a manifestation of many diseases. Just like we learnt in kidney, nephrotic syndrome, nephritic syndrome are not disease, they are manifestations, and which includes many other disease. Similarly, cirrhosis is not a diagnosis, cirrhosis is just a manifestation, or you can say is a end stage manifestation of many liver pathology. Now, once cirrhosis has happened or cirrhosis has set in, like this condition, in this case a biopsy, we will not be able to say what is the etiology of cirrhosis. Okay, so cirrhosis has to be diagnosed, or the etiological factor if has to be confirmed, then the biopsy has to be done in the earlier stage. And once cirrhosis has set in, then almost all causes of cirrhosis will look the similar morphology, and the etiology cannot be ascertained from the biopsy. The other important point about cirrhosis is that not all cirrhosis leads to end-stage liver disease and vice versa. Now, what does that mean? That some chronic disease will go to end stage without having cirrhosis, like primary biliary and sclerosing cholangitis, as well as nodular regenerative hyperplasia. So these two conditions, the liver will end or it will not be functioning properly, but there will be no morphological features of cirrhosis. There are other conditions which may have cirrhosis but do not progress to end stage liver disease. Okay, so the morphology will be like cirrhosis, that is fibrosis and nodules of regenerating hepatocytes, but they will still be functionally okay, and that is in controlled autoimmune hepatitis as well as treated hepatitis B and C infection. Okay, so we have discussed about cirrhosis. Now let's see how cirrhosis is classified, or how we can etiologically or based on the morphology we can classify cirrhosis. First, based on etiology, it can be alcoholic cirrhosis, and alcohol is the most common cause of cirrhosis and accounts for 60 to 70% of the cases. Second comes post-necrotic cirrhosis. This post-necrotic cirrhosis is because of hepatitis B and C infection, and that accounts for 10%, and the incidence has been going down because of the vaccination for hepatitis B. Next comes biliary cirrhosis, which accounts for 5 to 10%, and then there is something called as hemochromatosis, where there is excess deposition of iron in the liver. We will discuss later, and that accounts for around 5% of cirrhosis. So these are the most common, but there are many other causes like cirrhosis in non-alcoholic steatohepatitis, cirrhosis in Wilson's disease, which is a problem with copper metabolism, cirrhosis in alpha-1 antitrypsin deficiency, cirrhosis in autoimmune, as well as cirrhosis related to drugs. So there are many based on etiology, but the end stage or the morphology for all is one. Okay, so you will have basically nodules as well as fibrosis. So nodular hyperplasia, or these are hyperplastic nodules or regenerative nodules, and in the intervening areas you will have areas of fibrosis, and the morphology remains the same. So if you see here, this is a normal liver, okay, and you see how the parenchyma looks like, how the surface is smooth, but when we see a cirrhotic liver section, you can see how it looks like. There is multiple small and, or you can say, variable size nodules throughout the surface, okay, and the surface is also irregular. If you feel them, this will be more soft in consistency, whereas this will be more firm in consistency. Depending on the gross appearance, that was based on etiology, this is based on gross appearance. The liver can be micronodular cirrhosis and the nodules are less than 3 millimeter. And then there can be a macronodular cirrhosis like here, where it is more than 3 millimeter the size of nodules. And then there can also be a mixed, where you have micro as well as macronodular. And mostly how it happens, initially first it will be micronodular, and this micronodular usually progresses to macronodular cirrhosis. Okay, so what are the causes of micronodular cirrhosis? You have to remember, because there can be MCQ as well as Viva questions relating to micronodular and macronodular cirrhosis. So the first cause is alcoholic liver disease, second is hemochromatosis, third Indian childhood cirrhosis, and fourth chronic biliary obstruction. So these four causes predispose to micronodular, but again I would like to stress that it starts with micronodular, but many of them may progress to macronodular. So there is no hard and fast cutoff that this is definitely micronodular. So even alcoholic liver disease, predominantly micronodular, though may also have macronodules. Okay, but just like that, for classification we have put them into micronodular as well as macronodular. Now the macronodular most important cause is post-necrotic, that is relating to hepatitis B and C, and the second is primary biliary cholangitis, the third is alpha 1 antitrypsin deficiency. So the causes of micronodular as well as the causes of macronodular, at least try to remember 2 in each. Here alcoholic liver disease and hemochromatosis, here post-necrotic and primary biliary cholangitis. Now let's discuss what are the risk factors for cirrhosis. First, there has to be a genetic predisposition, and the genetic diseases commonly encountered are hemochromatosis, alpha 1 antitrypsin deficiency, Wilson's disease in relation to copper abnormality, then there can be storage disorders as well as biliary cirrhosis. The next is lifestyle, and we know alcohol is the most common cause of cirrhosis, and that depends on the duration as well as the amount of consumption of alcohol. When we bring into gender into equation, that women are more susceptible, that is because of estrogen, which increases permeability or gut permeability to endotoxins from the gut. Okay. In addition to that, again autoimmune hepatitis is also common in females, so females are more likely to develop cirrhosis as compared to male if they consume the same amount of alcohol. The fourth is ethnic as well as genetic differences. Now we have already discussed in alcoholic liver disease that variation in enzyme that is involved in alcohol detoxification that varies to person. So genetic and ethnic differences will decide that one person may develop cirrhosis, the other person may just stop at hepatitis or steatohepatitis. Now what are the comorbid conditions that predispose? We have discussed NASH, sarcoidosis, malnutrition, and these are some of the comorbid conditions if they are existent, or you can say if there is a hepatitis. So if these conditions are there, then they will again predispose to cirrhosis. Okay, so these are some factors, and then I have already told you infections like hepatitis B and C. And in addition to that, you may also find some cases which will be classified as cryptogenic, because in pediatric patients as well as in adult patients, around 1/5, you can say around 20% to 40% cases, we will not be able to say what is the cause of the cirrhosis. Okay, what is the cause? So these cases will be classified under cryptogenic or cause not known. And when we examine cirrhotic liver under the microscope, we have already discussed it. We will just revise that there will be loss of normal architecture with the formation of regenerative nodules and then bands of fibrosis. Nodularity indicates regenerative tissue, while the depressed areas correspond to the bands of fibrosis. Some special stains can be used in liver biopsies to confirm fibrosis as well as to find the etiology or confirm the etiology. So what are the stains? Reticulin and Mason's trichrome are used in all liver biopsies just to demonstrate fibrosis. And if you see here, this is a Mason's trichrome stain where this is the regenerative nodule and this blue color is bands of collagen. Okay, so Mason's trichrome helps in confirming collagen, and all these patient stains can be MCQ questions for you. Next is pearl stain. Now Pearl's Prussian blue stain is used in hematochromatosis to confirm iron, and here you see the iron deposits are staining blue in color. Okay, so this is Pearl's Prussian stain, and that is used for hemochromatosis. The next is rubianic acid or cicata stain, and that is used in copper abnormality, and that is Wilson's disease. The fourth is PAS stain with diastase. So PAS is per iodic skiff. Okay, so PAS stain along with diastase, it will be positive in alpha 1 antitrypsin deficiency, and here you can see the globules of alpha 1 antitrypsin staining pink color with, you can say, a PAS stain with diastase. So we can confirm, if you find these globules, we can suspect that the patient may be having alpha 1 antitrypsin deficiency. Then a genotyping can be done to confirm the exact etiological factor. Once a patient develops cirrhosis, there can be many complications, and those complications can lead to death in alcoholic cirrhosis or any kind of cirrhosis. So what are the causes of death? First is massive GI bleed, and it can happen from the varices of esophagus. Okay, so massive esophageal bleed can lead to death. Second is hepatic encephalopathy, and that is because of increased ammonia levels due to decreased clearance by liver. In addition to that, increased bilirubinemia, it predisposes to infection, as well as your ascites can also get infected, and that is called as spontaneous bacterial peritonitis, and infections can lead to septicemia and then cause death. The fourth complication is hepatocellular carcinoma, and hepatocellular carcinoma is a complication of cirrhosis, and it is more common in hepatitis B and C as compared to alcoholic cirrhosis. So these are some of the common causes that lead to death in case of cirrhosis. Let's take another case scenario before we move ahead in our session. So this time it's a 45-year-old obese female with history of diabetes as well as hypertension. So she is obese, she has diabetes mellitus, she has hypertension. Okay, and then she complains of gradual weakness, anorexia and weight loss. So weakness, anorexia and weight loss are non-specific symptoms, and you cannot fix them to any specific disease. Okay, so they are non-specific. On evaluation, there was mild jaundice. Now once you include jaundice into the equation, then this favors there is some liver pathology. Okay, and then we will see, then on evaluation she revealed ascites and splenomegaly. There was ascites plus there was splenomegaly. Okay, she gave history of alcohol intake once in a while. So she was not a regular consumer of alcohol, or she did not consume alcohol regularly. So she has ascites, she has splenomegaly. All these favor a possibility of cirrhosis, and that can also explain the jaundice that this patient is having. So most likely the patient is having cirrhosis, and what could be the etiological factors? In the previous case scenario we saw that it was because of alcoholic liver disease, but here she gives history that she is not taking any alcohol, as well as she is obese, she is diabetic and she is hypertensive. So all this indicates towards NASH or non-alcoholic steatohepatitis, and this NASH can lead to cirrhosis, and cirrhosis can cause all the other symptoms like ascites, splenomegaly and the other complications. So let's see what is the most probable diagnosis. The most probable diagnosis is cirrhosis, and that is because of a non-alcoholic cause. Okay, the previous one was alcoholic, here it is non-alcoholic, and if you combine hepatitis, hypertension and obesity, all this indicates towards a metabolic condition, and this metabolic condition in otherwise common in NASH or non-alcoholic steatohepatitis. Describe the etiopathogenesis of the diagnosis. We will discuss that. Describe the morphological changes in the target organ or in the liver. That also we will discuss in our subsequent session. So what is non-alcoholic steatohepatitis? So this non-alcoholic steatohepatitis looks very similar to alcoholic liver disease or alcoholic steatohepatitis. If you look at a biopsy, by looking at the biopsy, you cannot say whether the patient is alcoholic or non-alcoholic. The history of alcohol consumption is very important to differentiate NASH versus alcoholic steatohepatitis. So, NAFLD is non-alcoholic fatty liver disease. There it was steatosis or alcoholic steatosis. Second is NASH, non-alcoholic steatohepatitis. So, this non-alcoholic steatohepatitis is NAFLD plus there is a inflammatory component. So, fatty liver plus inflammation was there. Here also you have fatty liver plus inflammation. Only thing missing is alcohol. Now, this is also a common cause of liver dysfunction, and it is associated with insulin resistance and metabolic syndrome. That's what I mentioned in the case scenario, because our patient had diabetes, our patient also had obesity, our patient had hypertension. So, in addition to that, these patients can also have dyslipidemia, and this can lead to cardiovascular complications. Okay, so in metabolic syndrome, they will have hypertension, obesity, dyslipidemia as well as hypertension, and when there is a liver dysfunction in a patient with this metabolic syndrome, then a NASH possibility is kept top in the priority. What is the pathogenesis to NASH? First, there is insulin resistance, and then because of that, there is release of fatty acids or because of the overactivity of lipoprotein lipase. So, insulin resistance will lead to increased activity of lipoprotein lipase. Okay, so once this activity is there, as well as there is decreased fatty acid oxidation, So what this will do? This will lead to increase fat in the hepatocytes or accumulation of fat in the hepatocytes. So fatty acids are stored in the hepatocytes, and once the hepatocytes are rich in fat, they can undergo lipid peroxidation. So fat-laden cells or hepatocytes are prone to lipid peroxidation, and this lipid peroxidation, because of the damage to mitochondria, will lead to cell injury and cell death. Once there is cell injury, there will be release of inflammatory cytokines from the Kupffer cells, that is TNF alpha, and then that will activate the stellate cells. The stellate cells are fibrogenic, so they will lead to fibrosis, or in NASH you will have NASH can progress to cirrhosis. Okay, so once there is activation of the stellate cells, then NASH can progress to cirrhosis. So I hope you have understood the pathogenesis here. I will again elaborate, that is insulin resistance leads to increased lipoprotein lipase activity and decreased fatty acid oxidation. So once there is increased fat, this fat is accumulated in the hepatocytes, and the cell rich in fat are actually prone to lipid peroxidation, and this lipid peroxidation will lead to cell injury and death. So this cell injury will release cytokines that will activate the stellate cells. Stellate cells will cause fibrosis. So that is how NAS can progress to cirrhosis. Now what is the outcome of non-alcoholic fatty liver disease? Now non-alcoholic fatty liver disease can progress to inflammation, that is non-alcoholic steatohepatitis. Or NAFLD is reversible condition that keeps coming and going. If the metabolic syndrome is controlled or is taken care of, then this NAFLD will come back to normal. Otherwise, this NAFLD will progress to NASH, and NAS over a period of time can progress to cirrhosis, as well as NASH can progress to hepatocellular carcinoma also. Okay, so cirrhosis can also go to carcinoma, or it can directly also go to hepatocellular carcinoma. So that is the outcome of non-alcoholic fatty liver disease. So what are the clinical features? Mostly they are asymptomatic, and the manifestation will be in relation to the metabolic syndrome. When we do a liver function test, that will be mildly deranged aminotransferase in case of NASH. And when we do a biopsy, and this biopsy is a must because it is assessment of the degree of fibrosis as well as to exclude coexisting diseases. Normally, a biopsy is not done in alcoholic liver disease, but when you are suspecting NASH, a biopsy is done in order to assess the degree of fibrosis as well as existing other, to exclude coexisting pathological conditions. When we examine them under microscopy, the morphology is same as alcoholic liver disease, that is steatosis, ballooned hepatocytes, lobular inflammation, and only thing that will help you to differentiate is the clinical history of absence or minimal intake of alcohol in case of NASH, where there is plenty of alcohol intake in case of alcoholic steatohepatitis. So next go to another cause of cirrhosis or common cause of cirrhosis, that is hemochromatosis. In hemochromatosis, there is excessive accumulation of iron. Normally, liver has around 1 to 2 grams of iron, but in hemochromatosis, the load goes up to 50 to 60 grams of iron in the liver. Okay, so that is what is hemochromatosis, and this is a slow and progressive disease, and it manifests around 5th and 6th decade of life. So around these patients will progress, or they will go to cirrhosis directly, and this cirrhosis will come around say 50 to 60 years of age, and male is much more as compared to female, because female have blood loss in regular menstruation as well as childbirth, and then they also have nutritional deficiency of iron. Okay, so this hemochromatosis manifestation is much more in male, and it comes much earlier in male. Now this can be primary or hereditary, and that is autosomal recessive, and that is mutation in certain genes, like at least you remember HAMP as well as HFE. Now this HAMP is more common in young, whereas in adult this HFE gene is, or you can say this HFE gene is more responsible for adult type of hemochromatosis. And what happens in all this? There is absence of hepcidin. So this hepcidin, there is excessive absorption of iron from the gut, and they will be deposited in the liver. Okay, so there is no negative regulation of hepcidin, so there is excessive absorption. Now the secondary or acquired form of hemochromatosis comes because of the accumulation in other disorders, like you can say transfusion in hemolytic anemias. Okay, so if you give IV transfusions in hemolytic anemia, a time will come when excess of iron will be deposited in all tissues like liver, bone marrow, as well as other organs. Okay, so that was about hemochromatosis. Now we will take a look at what is the mechanism of injury in case of hemochromatosis. Again, here it is the most important, that is free radical injury or free radical formation, and that leads to lipid peroxidation, and this lipid peroxidation will release lot of cytokines. So, and those cytokines will activate the stellate cells, and that stellate cells will lead to fibrosis. So which are the organs involved? Most common is liver, pancreas and heart that is myocardium, as well as many endocrine, pituitary, adrenal, thyroid. So all these endocrine organs can also have deposit of iron. Now the clinical picture has many manifestations, but you have to remember at least the triad which define hemochromatosis, that is micronodular cirrhosis, which is seen in all patients or 100% of patients, whereas diabetes mellitus is seen in 3/4 or you can say 75% of the cases, as well as skin hyperpigmentation, that is because of increased melanin, and that is called as bronze diabetes, and this is also seen in around 75% of cases. So the triad of, you can say, micronodular cirrhosis, diabetes mellitus and skin pigmentation, they indicate towards hemochromatosis, but there can be other problems also like cardiac dysfunction as well as atypical arthritis because of iron deposition in the synovium. Okay, so deposit in the synovium will make the synovium inflamed, and that will lead to atypical arthritis. So these are some of the clinical features. Now we have to do some lab investigations in order to confirm hemochromatosis. So what are the lab tests? One is iron studies, and that raise serum iron, ferritin, as well as the percentage saturation of iron, and then there will be reduced total iron binding capacity. So raised serum, ferritin and percentage saturation, whereas reduced IBC, and this can be again a MC. When we look at the liver gross, then the liver will be dark brown to chocolate in color, and that will be micronodular, but micronodular can progress to macronodular. Okay, and the important thing is there will be no inflammation. Whereas in the other type of hepatitis like alcoholic liver disease as well as NASH, we were finding inflammation. Here there will be no inflammation, and what we will appreciate is fine golden brown pigments in the periportal hepatocytes in the early stage, but these deposits or these fine golden brown pigments will increase and involve throughout the parenchyma, including the bile ducts as well as Kupffer cells in the later stages. Okay, and when we examine them under the microscope, this is the golden brown pigments of hemosiderin. Okay, golden brown pigments that is there in the liver hepatocytes, and when you do a pearl stain, then we can confirm that this is iron and not any other deposit with this blue color. So you have to remember MCQ that for hemochromatosis we need a Pearl's Prussian blue stain, and the iron will be stained as blue. Okay, so with that we have completed hemochromatosis, and now we will look at some complications of cirrhosis. We have already seen what were the cause of death, but here we will see what is the other complications. First, cirrhosis can lead to portal hypertension, and then all the complications start. So there can be portosystemic shunts, and that will lead to esophageal varices which can bleed. Okay, so portosystemic shunts. Second is congestive splenomegaly, and this can lead to hypersplenism, so pancytopenia. Okay, then there can be ascites. Now ascites can get infected, that is called as spontaneous bacterial peritonitis. Okay, in short it is written as SBP, and this SBP may lead to septicemia, and septicemia may cause death. Then there can be hepatic encephalopathy, as well as there can be hepatopulmonary syndromes. In addition to that, there can be multiple endocrine complications of cirrhosis. So we will discuss these endocrine complications little bit in detail. So what are the endocrine complications? In male, the manifestations will be different in male as well as female. So let's have a look first at the male. So because of hyperestrogenism, there will be increased chance of feminization in case of male. And what will be the manifestation? that is gynecomastia, as well as female body habitus. There can be spider angioma as well as palmar erythema, and all these indicate that the patient is having hyperestrogenism, as we had seen in our first case scenario. Okay. So, and what is the cause of this hyperestrogenism? There is a reduced catabolism of estrogen as well as portosystemic shunt that allows the hormone to bypass the liver. So that is the reason why male will have hyperestrogenism and they will have manifestation of feminization. Then there can also be hypogonadism, and that can be because of direct toxic effect of alcohol as well as testicular atrophy, and this will lead to impotence in male. When we talk about female, feminization, like excessive estrogen effects will not be there that much, but they can also have gonadal failure leading to oligomenorrhea, infertility as well as ovarian atrophy, and all these because of the direct effect or direct toxic effect of alcohol on these organs. Okay. With that, we have completed our discussion on alcohol liver disease and cirrhosis. Now we will take a comparison at alcoholic cirrhosis versus post-necrotic cirrhosis, or this is called as hepatic cirrhosis. Okay, how they look different. Etiology, here it is chronic alcoholism, here it is hepatitis B and C. So you have to remember that post-necrotic hepatitis means the hepatitis because of B and C. The pathogenesis of injury is because of the metabolite of alcohol, that is acetaldehyde. Whereas here the injury is by the virus as well as the immune response of the host. When we look at the gross, here it will be shrunken and uniform micronodularity, whereas in post-necrotic it will be distorted as well as there will be macronodularity. In microscopy, here the nodules will be small, uniform with thin septae, as well as you will find Mallory hyaline bodies. Here the nodules will be variable sized with thick septae, and you will find apoptotic bodies, otherwise called as Councilman bodies. Okay, they are also called as apoptotic bodies. In viral hepatocytes or hepatitis, they are called as Councilman bodies. Now both we know cirrhosis can lead to hepatocellular carcinoma, but the chance of progression in alcoholic, yes, it is there, but it is less, whereas the chance of post-necrotic hepatitis going to HCC is strong, and that is even more than what it is in alcoholic liver disease or alcoholic cirrhosis. Okay, so with that we have come to the end of our discussion. Now let's take a look at few MCQs. First, name the conditions that are associated with the Mallory hyaline bodies, and this can be a short note or you will get MCQ Mallory hyaline or Mallory Denk bodies. So what are the conditions associated, or this Mallory Denk body is associated with which condition? First, alcoholic hepatitis. We have learned even in NASH, it can be seen in primary biliary cirrhosis, it can be seen in Wilson's disease as well as hepatocellular carcinoma. So you have to remember these 5 causes as the most common cause of Mallory Denk bodies, that is alcoholic, NASH, biliary cirrhosis, Wilson's disease as well as hepatocellular carcinoma. So let's go to the next question, that is, what is the most common cause of death in advanced cirrhosis? So you have to answer this. The most advanced cause of death is because of varices, and that is because of esophageal bleed. Okay, esophageal bleed will lead to shock, and this shock will lead to death. So this is esophageal varices is an emergency condition. The next question, which of the following condition is not associated with non-alcoholic steatohepatitis? So which is not a feature of NASH? Obesity, diabetes mellitus, hypertension and dyslipidemia, which is not associated with non-alcoholic steatohepatitis. So if you see, all these features are associated with NASH. So here there is no option which is not associated. If you have to choose one, then probably it will be hypertension, but if you see, then even hypertension to some extent is related to NASH, because NASH is seen in metabolic syndrome. Okay, so here if you have to choose one answer, then it has to be hypertension. Next question, which of the following feature is not seen in cirrhosis? Not seen. Okay, splenomegaly, ascites, gynecomastia, pancytopenia and neutrophilia. So which of these is not seen in cirrhosis? Splenomegaly, yes. Ascites, yes. Gynecomastia, because of hyperestrogenism. Pancytopenia, because of hypersplenism, but neutrophilia is not seen in cirrhosis because this is seen in alcoholic steatohepatitis. Okay, so in steatohepatitis you will find neutrophilia or leukocytosis with neutrophilia, but in cirrhosis it is pancytopenia. The next question, which of the following features is not a part of alcoholic steatohepatitis? So here it is alcoholic steatohepatitis. First, ballooned hepatocytes, spotty necrosis of hepatocytes, neutrophilic satelitosis, Mallory-Hyland bodies or Mallory-Denk bodies, chicken-ware fibrosis, and it is an irreversible condition. Which of these is not a part of alcoholic steatohepatitis? So if you can recall the discussion, then all these first 5 features are associated with alcoholic steatohepatitis, but here in the 6th it is mentioned that it is an irreversible condition, but the steatohepatitis is actually a reversible condition. Only cirrhosis is an irreversible condition. Barring that, steatohepatitis as well as steatosis both are reversible condition. With the questions, we have concluded our discussion. Now we will summarize what we have learned throughout this session. First, alcoholic liver disease is a chronic disorder having 3 stages of evolution. The first is steatosis, second it is steatohepatitis where there is inflammation, and the third is end-stage liver disease, that is cirrhosis. Now the amount is also important, that is more than 80 grams of alcohol per day, and the duration is also important, that is more than 10 to 15 years. If both are existing together, there is a possibility of development of cirrhosis, and this happens in around 10 to 15% of alcoholic liver disease. So all patients with ALD will not go to cirrhosis, only 10 to 15% will go to cirrhosis. Third, steatosis and hepatitis stage are both reversible, whereas cirrhosis is irreversible. So what is the cause of injury or the mechanism of injury? In liver disease, you have to remember free radical injury, altered redox potential, as well as aldehyde proton adducts, and these 3 are the basic mechanism by which alcohol causes liver injury. Now, coexisting liver pathology have synergistic effect on progression to ALD. And what is the coexisting pathology? Like if there is hemochromatosis, if there is hepatitis, if there is metabolic syndrome, then all these will again act in a synergistic effect to increase the progression of ALD. Non-alcoholic fatty liver disease or non-alcoholic steatohepatitis are associated with metabolic syndrome, that is insulin resistance, diabetes mellitus, obesity, hyperlipidemia, as well as they can also be associated with hypertension. I have mentioned all these cannot be morphologically distinguished from ALD without clinical history. If you see a biopsy, if you find steatohepatitis, then you can never be sure whether it is from a alcoholic liver disease or it is from a NSSH, because both will be same looking. Here there is alcohol history, whereas here there is history of metabolic syndrome and no alcohol. Okay, so that is how they are decided. Hemochromatosis is excess of storage of iron in our body, and that is another cause of cirrhosis. Around 5 to 10% of cirrhosis cases come from hemochromatosis. Now it can be primary AR or autosomal recessive disease, that is because of the deficiency of hepcidin, whereas it can also be secondary because of excessive transfusion in hemolytic anemia. Okay, the clinical features are cirrhosis, diabetes mellitus, skin hyperpigmentation, as well as gonadal atrophy. And if you find this triad, then we can say that the patient is most likely having hemochromatosis. With the summary, we have come to the end of this session. I hope you have understood the concepts and all the detailed principles of alcoholic liver disease as well as its progression to cirrhosis. Thank you so much.